Hello, everybody, and welcome back to New Books in Medicine, a podcast channel on the New Books Network. I'm Claire Clark, one of the hosts on the channel. Today, we'll be talking to Sarah Rodriguez about her fascinating new book, The Love Surgeon, a story of trust, harm, and the limits of medical regulation. Sarah Rodriguez, welcome to the show.
Thank you so much for having me.
Sarah, I wonder if you could begin by telling us a little bit about yourself.
So I am trained in the history of medicine, and I teach at Northwestern University, where I teach the history of medicine to both medical students as well as undergraduate students. And I also teach on bioethics as well. And my research interest and my teaching interests then combine as far as, well, my research interest and my teaching interest combine and overlap, and that I'm interested in the history of women's reproductive health, as well as the history of the ethics of clinical care and the ethics of clinical research, the history of both of those two.
So how did those interests lead you to write The Love Surgeon?
So I learned about The Love Surgeon actually when I was still in graduate school. One of my professors, Sharon Wood, mentioned this doctor in Ohio to me, and I kind of kept it in the back of my head. And I read about, I started doing a little bit of research about him, and I became more interested in it because the initial story about Burt is that he did this surgery that he came up with on his own that does not appear to have been used by anybody else on women after they gave birth, because he thought women were made wrong, basically for missionary position heterosexual sex. And I thought, how did this happen? How could he do this for so long and not be stopped? And then I became more interested because it's a bit more messy of a history than what I just said. And being a historian, the messiness of history is what's so interesting. So the more I sort of looked into it and the more layers there were to this is what kept me kind of interested in finally deciding that this is there's enough here that there could be actual book about it.
So maybe we could start by just backing up a bit, and if you could tell our listeners, who is this guy, James Burt?
So James Burt was an obstetrician gynecologist who practiced his whole career in Dayton, Ohio. He was a very popular gynecologist and obstetrician. He delivered a lot of babies during his time. And at some point probably around the mid-60s, 1960s, he practiced from the late 1950s through 1989, early 1989. But sometime probably around the mid-1960s, he began sort of altering a bit an episiotomy repair. Now, an episiotomy is the cut gynecologists, obstetricians would make during the labor of a woman. So when the baby's head is about to be delivered through the vaginal canal, some physicians made a cut to expand the opening of the vagina to better enable the baby to come out. This was a very common procedure in the United States in the 60s and 1970s. But Burt then, on the repair of that, because you need to sew it back up once the baby's been delivered, started making some alterations that over about the next couple of years, next decade or so, became much more involved than just the sewing up of the repair. And he began making some more additional, pretty detailed, I'm going to say, and pretty extensive alterations to the episiotomy repair over time doing this. And his reasons for doing so were he thought he was better enabling women to enjoy sex after giving birth. That his idea was that women's bodies, he was essentially correcting women's bodies, and that at some level he starts saying things like women's bodies are not made correctly for a particular type of heterosexual sex, particularly the missionary position. And he felt by making these adjustments to the episiotomy repair, he was improving upon the female body for that sort of activity.
So what kind of adjustments was he making in this? Did he call it love surgery?
He did. So he ends up calling it both surgery of love as well as love surgery over time. And so in addition to making the opening of the vagina smaller when he did the episiotomy repair. He actually changed the angle of the direction of the vagina. So it was more pointed down. And he did this by cutting a muscle that supports the vagina. For anyone familiar with Kegel exercises, when you do a Kegel exercise, you're squeezing the muscle that he cut. And then he also added circumcision of the clitoris, which is removing the foreskin of the clitoris. So the clitoris is still there, but it's the foreskin that's removed. So those are the sort of major components that he did. So he essentially redirected the vagina, the direction of the vagina, as well as cut a muscle and then remove the clitoral hood of the clitoris. He might not have done the latter to all women. That's a bit unclear, but that was a component of the surgery as well when he kind of sees that he's sort of perfected it, which is by the mid-1970s.
That seems like a pretty drastic surgery.
And beyond the sort of scope of episiotomy repair, I think we could say too. Like initially, that's where he claims he started it from, but obviously it's a bit more involved than sewing up the cut of an episiotomy.
Can you say a little bit more about how was the development of this surgery? What about it was normal? Like within the normative surgical development, I think it's the term that you use. And then in what ways was it obviously out of bounds even for the time?
So one thing that's normal about how surgeries develop is many surgeries develop through experiential practice. So surgeons might try a different suture or try a different technique or notice that if they cut a different way that they have a better outcome. So some of those a surgeon might make a change and then see that the patient who they made the change upon maybe had a faster healing time or had less complications, that there's some better outcome by this change. Oftentimes, maybe they'll do it on a couple more patients and then maybe start talking about it with other surgeons. So this experiential learning about surgery, experiential change about surgery is a really normal way of surgeries developing, and not necessarily seen as making a new surgery. Sometimes they go that route, but sometimes it's just maybe a tweak within an existing surgery. So in that sense, what Burt was doing was pretty normal for how surgeries develop. He's using his experience. I will say when he started making his change to episiotomy repair, he claims that some women he'd done it upon, and I should say he's doing this when women, after they've given birth, he's not asking explicit consent to be doing this, but then to do an episiotomy or episiotomy repair in the 1960s and 1970s, you would not have gotten a consent anyway. So in that sense, this is also normal for what he was doing. But to back up to his surgery, he's making these changes and he's not telling the women he did anything different. And he's claiming that the women that are coming to him and saying, hey, my sex with my husband is actually better after giving birth than it was before. So he's taking this information and he's claiming women are telling him, and that's then he's sort of furthering his surgery along in that sense. So his basis, how he goes about developing the surgery based on making a change, seeing that the outcome is somewhat better, different, and then continuing along that path, that's a fairly normal practice. I'd say where Burt's practice deviates dramatically from surgical development in general as a normative practice is his idea that women's bodies were somehow made wrong. So, and it's not just a particular patient who's maybe having a particular problem. At one point, he basically says all women's bodies are essentially made incorrectly. So he's seeing basically the female body is needing correction, not a female body. And that to me is the big difference where he sort of goes dramatically different on normative surgical development.
Did he promote the surgery that way? How did he promote it? That doesn't seem like that would be very convincing. Hey, all women, your bodies are made wrong. Come see me.
Yeah, like I've got the cure for. So what he ends up doing, he develops this surgery largely in his obstetric patients, and by around mid 1970s, mid to late 1970s, he feels like it's developed to the point where he can now essentially market it as a standalone surgery. And that's what he ends up doing, is telling women, hey, there's a surgery he's now calling love surgery or surgery of love. And he's offering it as an elective surgery, essentially. He's doing it but he's advertising it more as a sexual benefit to the woman. So that's how he's promoting the surgery, is it'll improve your sex life, essentially.
And where did he promote this? So, I mean, he was trying to get things published in the peer-reviewed literature. It also seems like he was just trying to get general media attention. Can you tell us a little bit more about what his strategy was for attracting patients?
So he is on the Donahue show early on, which for those of you who aren't old enough to remember, the Donahue show is a big syndicated television show where Phil Donahue interviewed people, kind of like an Oprah-ish type of show. And it actually originated in Dayton, Ohio. So he was on that, which was a big deal. He had articles about him in a couple of popular magazines like Playgirl. He was at one point interviewed on both local radio as well as a couple of national, like there was an LA program he was on. So he's getting some press that way. He also appears to have been sort of working with press agents to try to get PR sort of department to kind of get the word out about his surgery as an elective surgery that would improve the sex lives of women, he was claiming.
How did the medical establishment respond?
So this, I will say, is one of, I think, most interesting to me parts of this book, because when I went into it, the sort of popular media reports on it were very much, the local doctors did nothing. And that's not true. They did a lot of things, but they weren't necessarily in the public eye what they were doing. And this gets into the sort of trickiness of medical regulation and peer review and doctors regulating themselves. A lot of what they did was sometimes the very basic sort of form of medical regulation, or medical peer review rather, which is a doctor doesn't like what another doctor's doing, and so they don't refer patients to him or her. And that definitely happened with Burt. There was also cases where specific patients would talk to another doctor about the surgery and the possibility of having it, and that doctor would say, I don't think that's a good idea to go that surgery. So that's another way they were acting to sort of contain what he was doing. Finally, most dramatically was the local medical society, as well as some local OB-GYNs, pushed both the hospital where he mostly operated, which was St. Elizabeth, as well as the local medical society, created essentially a warning, I will say, by having the hospital create a special consent form to have the surgery, which that was not common in the late 1970s to have a surgery-specific consent form, especially one that said things like, this is not a standard surgery, this has not undergone peer review, which is what the consent form said. So the consent form was very, in one sense, it was a very direct of saying, this is not a standard surgery you're about to undergo, it hasn't undergone peer review. So in some ways, it was a very direct sort of consent form. But in other ways, like I say in my book too, you have to understand why it matters that this hasn't undergone peer review, or what it means to say a surgery isn't standard. So while in some ways it was really direct to the patient, saying, hey, what you're about to undergo is not sort of a typical surgery, you have to understand sort of the medical language of things like peer review and standard to get what they were saying. That said, it was a pretty profound thing that they were doing, of making him have a surgery-specific consent form. In addition, the local medical society of Montgomery County in Dayton, Ohio, they also had it appears they ran an ad sort of suggesting the surgery wasn't necessarily the best to be used, as well as if somebody called the county society and asked about the surgery, they actually had basically the same statement as what the consent form for the hospital was using, which was, has undergone peer review, this is not a standard surgery. So while it's not maybe explicitly saying we don't recommend this surgery, by having that language of not peer reviewed, not standard, they're essentially saying this is not a surgery we recommend.
And so is that the limits of medical regulation in your title?
I think the limits of medical regulation for me is a lot of doctors actually did a number of things, some of which were um, quite forward thinking, I would say, or quite bold in some ways. But there's a lot of limitations what a physician can do. Some of the limitations are time bound. A physician has to know that this particular patient had this particular surgery and these bad outcomes are because of that. That can sometimes take time, and you need to see more than one patient with it. So, sort of accumulating that this is not a good surgery isn't necessarily something that can happen rapidly. It might take time to accumulate that much evidence across patients. To me, the other big limits of medical regulation, though, are too, is like even when you have a surgeon like this, where there's a lot of people saying this person should be, at least contained or curtailed with what they're doing. But sort of to me, the limits of medical regulation are even when a physician maybe is challenging what they see as an abusive or unethical or unprofessional practice, that there's this challenge could take time. It could take time to gather the evidence. They might feel like they don't really know what's going on, so they might be hesitant to take steps toward saying something. There's also the very real fear of lawsuits by the physician they're challenging. So in a way, a lot of the medical limitations or the limits of medical regulation to me are, one, there's some limits with what a physician feels like he or she can do. And then two, how long it can take to have some actions actually happen toward the physician to limit and or end what they're doing.
How did women respond? I mean, I'm assuming he had some some patients that loved the love surgery and a lot that were harmed by it. I'm just wondering what the reaction was. I know you mentioned quite a bit of moral distress among the nurses who see what's going on and feminist groups who react to a little bit to what he's doing.
Yeah. So yes, there are some nurses who raised some deep concerns with the nursing staff at the hospital where he operated, which was St. Elizabeth. Um, and also, like you just said, there are some sort of feminist health activists in the 1970s. They also raised concern about the surgery, in particular that they see it as a very sexist surgery because, again, he thinks all women are basically made wrong for heterosexual sex. As far as the patients go, they're in at least sort of publicly coming out and saying they supported the surgery or they thought it was a great thing that happened to them. There are some interviews that happened with those women in the 1970s, a couple that come out in the late 80s after he's gone to trial for malpractice. But for the most part, some of the women who are saying that they had some adverse outcomes really feel like their trust was really profoundly betrayed. So I think in addition to having their bodies, some women had some pretty profound complications in addition to those very challenging complications, painful complications. A lot of these women also very much felt betrayed by their physician as well as the larger medical establishment by not sort of stepping in and not allowing him to do this surgery.
So in your book, you interweave the story of Janet Phillips with the story of what happens to Burt, sort of the rise and fall of his love surgery. Could you tell us a little bit about Janet Phillips and what happened to her?
So Janet Phillips went to Burt in the early 1980s. She was looking for somebody to give another piece of a second sort of an opinion that she needed a hysterectomy. And she went to Burt for that other opinion about that. And she ended up having a hysterectomy with him, but he also ended up doing love surgery upon her, as well as the hysterectomy. And I decided to use her story because she's the reason I find her so compelling is she's basically the first successful lawsuit against him that actually goes to trial. There's a couple of women who try to sue him in the 1970s for malpractice, but they don't actually go far enough to actually get to trial. She is the first to successfully go to trial. And her story I find to be compelling because she was a pretty brave woman to go forward with this and to have to speak about some of the pain she was going through with this surgery publicly and to bring forward the lawsuit against him. So I interweave her story with the Burt story to have it not solely be focused on him, but to show that there are other people obviously involved in this story. And to me, she's a central plays an incredibly central role in this story because, again, she's the first one who is able to legally challenge him and go to trial with it. And even though her trial doesn't end how she would have hoped, I think it would have ended, that initial trial, it does bring other women sort of forward with her story, and they also end up suing him and then suing the hospital too.
So if other women heard her story and sort of recognized what had happened to them, how did she find out what had happened to her?
She, one of the things with James Burt was he apparently had a very solid, reassuring bedside manner. So a number of women, even when they were experiencing problems post-love surgery, which for a good deal of them, they didn't know they'd undergone. And so they just sort of assumed their problems were because of either delivery or some other surgery they'd had. So they weren't clear that this was because of a surgery they didn't really understand that they'd undergone. He was very reassuring, and oftentimes women stayed with him for a number of years because they liked his reassuring. He also seems, though, in addition to the reassuring, he also seems to have been sometimes used some sort of scare tactics with the women, like, other surgeons aren't as good as I am, or they're not going to understand that this surgery is more complicated than they can do, et cetera. So that he kind of made them fearful oftentimes of going and seeking another physician because he basically was like, I know what I'm doing, and they don't, essentially. Phillips, though, at a certain point, keeps having repeated infections and keeps having pain, and he does not seem to have an answer for them. So she does stop going to him, and eventually she ends up going and seeing two other OB-GYNs, one of whom then actually undergoes some actually sort of corrective surgeries with her. So she essentially finds out because she finally seeks another physician opinion and help and care.
What happens? Can you tell us a little bit about what happens to Burt?
I think this is going back to your what's the limits of medical regulation question. What ends up happening with James Burt is Janet Phillips and a couple of the other women who see that they have a similar story because after Phillips goes and sees this an OB-GYN, she also then goes and sees an attorney. And this particular attorney had also been a nurse, which I think was probably helpful in her understanding sort of the medical complications that were going on with these women. But a number of women then start coming to this particular attorney. And this attorney, Mary Lee Samble, as she says, she's trying to complain to everybody she can about that Burt should stop practicing. And actually, by the late 1980s, as far as we can tell, Burt probably wasn't practicing love surgery anymore, but he still had his medical license. So Samble and the women that she's representing decide to go public, essentially, and they choose to be on a nationalized show that's kind of like a reviewer kind of called it a sort of a hyper kind of version of 60 Minutes. So they go on this national show and they start talking. And that's actually what sort of starts the ball rolling for sort of the limiting of Burt's medical practice, is this national exposure on national TV to say what these complications are that these women are having from this surgery. That's also how a number of other women then become aware of, they see this program, and then they become aware of, wait, I had surgery by this man and I'm having these complications. Maybe it's also because of this surgery. So a number of women become aware of what happened with them because they see this. Importantly, too, Burt gets exposed on national television. That's in the fall of 1988. And like I just said, that kind of is what starts moving the ball rolling very rapidly to have the state medical board start investigating Burt. They launch an investigation. They propose a hearing. But by January of 1989, instead of going through the hearing, which would have made James Burt would have had to have been very public then about a lot of things that he didn't want to be because he was being sued, he decides to just voluntarily rescind his license.
Can you say a little bit more about how state medical boards work and how they're supposed to work to regulate
So state
physicians?
medical, so state medical boards are the overseers of a physician being able to practice, and they they're supposed to then that is essentially the medical regulation of boards can limit a physician's practice. They could suspend it. They could maybe suspend their ability to prescribe drugs, so that they're the board who then basically is the oversight for physicians. And each state has their own board, so it's not a federal; it's at a state level with the boards of, and they're the ones who again innate or allow the licensing of physicians, and or can either take it away, or again, like I said, could somehow sort of limit the practice, not be able to prescribe drugs, for example, or perform a surgery, or et cetera. And that's the role of state boards. Historically, state boards have largely been seen as slow acting in sort of response to somebody maybe raising a concern. Also, historically, concerns are most often raised by patients and not by other physicians, which also to me is one of the limits of medical regulation. If medicine is a peer-reviewed process, hopefully more physicians would be talking about, hey, this physician's doing something I think should be investigated.
So why did it take so long for the board to start looking at Burt? If all of the physicians, if the physicians were taking out ads warning people and demanding that he use a special consent form. Right.
Yeah.
Yeah.
Why did it take another? Because they're doing that in the late 1970s. And so the state board claims that the county medical board never said anything to them. And even though this has been a long time now, and he doesn't have a license, I still don't have access, that it's not public, whatever happened with the board, other than you can see on there, like he had his license suspended or taken. Sorry, he rescinded his license in January 1989. So I don't actually know if the board investigated earlier, if they didn't. Like I said, the County Medical Society says that they told the board by the late 1970s, hey, you should be looking into this guy. But they claim to have no record of that happening. So it's a bit unclear when they started looking at him, other than they claim that they started looking at him in the late 1980s based on a complaint by a state legislator who had someone in his district say something about the surgery too. So there are a number of people raising complaints and issues and concerns with Burt. Definitely by the TV show time in late 1988, they had launched an investigation. But how much they were doing before that is the historical record is a bit unclear and or not public.
So how does Burt's story kind of track the development about the development of bioethics or clinical ethics in general? Like, is it because it seems in some ways it's like this is a whistleblower story, and nobody cares until it blows up in the media, and then suddenly, but it it might complicate that narrative in other ways too. So you could, I don't know, just tell us what's going on in the world of clinical ethics while Burt is doing his love surgery.
So, I mean, right now, I think for many of us, like if we think of anything about clinical ethics, we might think consent, right? If you need to get consent for things. Well, in the 1970s, consenting for stuff was still not a common practice. And in particular, basically for women going in to, let's say, give birth, essentially when you entered the birthing room or entered the hospital, you'd sort of consented, if you will, to what happens next. And so it wasn't sort of, you'd ask for every sort of procedure. You would just sort of assume, okay, you're here to have a baby. Whatever happens next, you've agreed to. So consent as an issue really starts growing, I'd say, in the 1980s. This individual consent really starts growing in the 1980s. So again, when I first entered this history of Burt and started looking at it, I really thought consent was this was a total issue about the clinical ethics of consent, and that didn't happen, and that's the big problem. Whereas I kind of think that that's in some ways a red herring now, because consent was just not being done by most practitioners in the 1970s. And in fact, there's even evidence to say that even though episiotomy itself has gone down now, that through probably the 1990s, early 2000s, that wasn't necessarily being consented for. So that to me is the kind of red herring, if you will. And the bigger issue is that this is about issues about abuse within medicine, and sort of thinking larger structural changes that have to change to encourage physicians that they can say something about a physician that they're finding problems with, and to have a safety that they can do that safely, but to know that is something that they can do safely and that they should be doing a more active job with it. So to me, it's the consent isn't so much the issue as this is a larger issue about particularly male doctors and issues of female patients and issues of mistreatment or outright abuse, but also even just more mistreatment and disrespect.
What lessons do you think we can learn from James Burt? Because there are some ways in which he's obviously an outlier, an exceptional case, could be a horror story, but there are in other ways, like you just said, maybe he's just kind of an extreme version of certain attitudes in medicine in general.
Yeah, so I'd say Burt in some ways is obviously an outlier. I mean, his ideas about the sort of extreme ideas about women and their bodies is hopefully an outlier. They're all made wrong essentially. But to that said, there still is historically an institutional power that men within medicine have had over women and their bodies, and I think that is not the outlier. So him being an extreme case, yes, but him sort of being this idea about institutional power, again, men have had within medicine, particularly over female patients, and the fact that so much of medicine then, and that it can be abused then by men in power because there's the secrecy of the exam room and the operating room or the delivery room where that can play out. And that women, too, when we talk about medicine and this abuse, that particularly for the women with the love surgery, like I've said, a lot of them didn't understand that something different had been done to their bodies. And so having that trust in the physician, having that really be abused because their bodies had happened that they didn't understand or they didn't know and they didn't connect.
So I noticed that the book has this really interesting appendix, a list of questions to ask if considering an elective surgery. I have never seen anything like this in a history of medicine monograph, and I just wondered if you could tell us a little bit about what it is and why it's there and how it relates to the rest of the book.
I've decided to put this appendix in with sort of questions to ask about surgery and when to have surgery, or whether the surgery is in your sort of best interests, as an outgrowth of this book, because to me, it's one. I mean, obviously, we go to physicians because we trust them, and for the most part, for the vast majority of time, that trust is well placed. But just to be clear about why a surgery is being performed and if there's another alternative, because I feel like with the story of James Burt and his surgery was so much about him and his sort of thinking about women and their bodies. It really wasn't about the sort of individual women and their needs. So it's a way to just encourage patients to sort of think about surgery and if there is another alternative to the surgery, but to raise these questions before you have surgery and while you're still thinking about the surgery, to make sure that you totally understand what the surgery is about. And if this is something that is still a new surgery, something they've performed a lot. So it's encouraging, I guess, more activism for the patient part of them, to just ensure they understand the surgery and to ensure that this is what is best for them, for what they have, and that maybe there are some alternatives. And I put this in They're partly also because surgery, I think, in some level in this country at least, has become so normative that, and we think of surgery as being an endpoint, right? That if I go and have this surgery, it's going to, whatever's happening with me, I'm going to be fixed and it's all better. That's not necessarily true, and not just meaning maybe you have complications, which is certainly a possibility with surgery that it might not, but it also could be that this might be a step and it's step one and there's 10 more steps. So surgery isn't necessarily an end point. It might actually be a beginning. So to understand surgery as being perhaps part of a continuum and not a fix. But then I will say I was hesitant to put it in uh, because to me, one of the lessons of the Burt story is that um, this can't just be about patients asking questions, right? This also has to be about physicians asking questions about each other and about what they're doing, and being able to safely do that and comfortably do that, and to be encouraged to do that. Because we've unfortunately seen a number of physicians more recently than Burt as well. And I'm thinking about the George Tyndall, who was the USC gynecologist, or we can think about Larry Nasser, who was the OB-GYN or gynecologist for the gymnasts in Michigan. Right? We've seen this sort of play out where there are physicians who unfortunately do take advantage of their patients, are abusive with their patients, exploitive of their patients, et cetera. So, like I said, I think it's important to ask these questions. I really do, as part of the process for patients to totally understand what is happening, why someone's suggesting this, if there are alternatives. But I was hesitant because, again, one of the lessons to me is this shouldn't just be on the part of the patient doing this activism. There should be structural support to make changes across the board about thinking about enabling physicians to more safely, again, come up and say, I think something weird is going on with physician X, and I'm not sure, and I think the surgery is maybe uncalled for, and having that be more of a structural change.
So, it seems like a lot of things, like there have been cultural and structural changes since James Burt was sort of promoting his love surgery. So, patient autonomy, the idea that women would come into childbirth with a birth plan or ask a bunch of questions about different surgical procedures. What kinds of what hasn't changed that much since James Burt resigned his license, or what changes might you like to see?
So I think one of the things that, to me, about this book and about, there have been changes, but what this book brings forward about some changes that still need to be brought forth is really educating physicians, whether they're in medical school, as well as sort of as once they're out practicing, is what does it look like to recognize a physician as doing something that is outside the standard of care, that is possibly exploitive, that is even possibly abusive to their patients. And then how do you go about educating on how do you go about actually trying to advocate for the patients, advocate to have this physician be looked at by the medical board, and to also then have it be that the medical board can look at a physician and have it be done in a way that is perhaps quicker than sometimes happens now, as well as I do think there needs to be some consideration um, about how transparent those investigations are as well as to think that maybe sometimes investigation doesn't necessarily mean that someone is doing something like investigation equals bad. It should also be investigation can also be seen as how can we improve, and that also needs to be emphasized too. So yes, there's been a lot with consent on the patient end. What I'm thinking is I think now there needs to be a bit more on the education part of students as well as clinicians on, okay, this is not just about protecting you from being a malpractice. You also have a responsibility as a physician in a peer community that relies on peer review at varying levels of what that looks like. Here at the clinical level, you have a responsibility then to be observant and to say something as well.
It certainly seems like we've gotten more litigious with with medical errors and things like that. I wondered, what do you think about the role of sort of self-regulation, like through medical boards, versus the role of the law?
I think one of the things I think I found so interesting with this book is, going in and thinking this is just about the boards doing. Well, no, it actually, this sort of regulation of medicine is actually much larger than just physicians sitting in a room and a board like discussing this. It's also patients, it's also the media, it's also legislators, it's also lawsuits. So there's multiple actors that are involved in medical regulation. And in some ways, I think that should also be made more clear to people as well.
Well, Sarah, we've taken up a lot of your time. What are you working on now?
So one of the things I'm working on now is actually the history of hysterectomy, and particularly the uptake of minimally invasive hysterectomy in the late 80s, early 1990s. So a bit more recent history than Burt, but also a bit overlapping. And this extends upon my interest, obviously, in surgery and how surgeries develop and how surgeries are taken up or not taken up. Because one of the things I think is interesting with Burt is, why didn't surgeons take it up, the surgery, versus, again, why then would they take up another surgery? So sort of tracing those two things I think are interesting. And so my next piece is on, I'm working on a history of hysterectomy, particularly I'm going to say since the 1970s.
Well, that sounds fascinating. That's another great project.
Hopefully, yeah.
How far are you along on it?
Oh, really early. Yeah, really, really early. So,
well, I will look forward to hearing more about that in the years to come. I want to thank you, Sarah, for being on the show today. I really enjoyed it.
Thank you. This was fantastic, and I greatly appreciate you having me on.